at the last minute, Richard helped me get a hold of Tom Fuchs, who he and I managed to have a communication difficulty where I sent something to the wrong email and he sent it back not to my email, and we didn't know that he was available, but he is available, so that's great. And Tom, as you guys know, has pioneered image-based AI methods and started another company that is doing that, and he's gonna kind of speak to us today about the advantages and limitations. I don't know what you're going to talk about exactly, Thomas, but I'm really glad to have you.
Thank you a lot, Sandy. Thank you for the invitation. Yeah, it was quite complicated, but great to be here. So for how long should I speak?
You know, shoot for about 20 minutes. And we, at the beginning, we indicated that this is a workshop, so people are welcome actually to interrupt you and ask questions during your talk. If you don't want them to, say so now, and we'll try and wait till the end. People have been pretty good about using that sparingly. You know, if it goes a little bit longer, we are all here, and it'll be because we're interested. So up to you.
Fabulous. Yeah, I'm trying to keep it short, and yeah, please interrupt me anytime. Also, I'm looking forward to the questions afterwards. So let me share the deck. Here we go. If nobody complains, I presume you're seeing that.
So my name is Thomas.
Perfect. My name is Thomas Fuchs. I'm the Dean of Artificial Intelligence and Human Health at Mount Sinai and the co-director of the Hasso-Plattner Institute for Digital Health at Mount Sinai and leading computational pathology efforts. Good. So you probably all know Mount Sinai. It's a great place in New York City. It's the largest hospital in the city, so we have the luxury of having a very diverse and large population, which of course is key to build robust machine learning and AI approaches in healthcare. I have one disclosure slide. Alex mentioned it. So I'm the founder of Page AI. That's a company we spun out of Memorial Sloan Kettering Cancer Center in 2017. Page stands for Pathology Artificial Intelligence Guidance Engine, which got the first breakthrough designation in pathology, and will maybe touch on a few studies, but mostly it's going to be an academic talk. Good. So where are we today in AI and in general? So as you know, it's really a split between hype and cynicism. So on the hype side, you have quotes like the Google CEO who says AI is going to be more profound than electricity and fire together, or AI will cure all cancer automatically. And on the cynical side, you have distractors who say it will never work, it doesn't work like a human, hence it won't work, etc., etc. What we are trying to do is to build systems that are useful for the clinician, for the pathologist, for the oncologist, and especially helpful for the patient at the end of the day. So wherever you are on the left or on the right here, I think we all want to build tools that are helpful and that are clinically grade. So they are not only research tools, but these are systems that can be used in clinical practice. So you all know how pathology works. I can certainly skip that part. So what you see here is the slide load at pathology of a single week. Each of the folders contains dozens of slides. And as you can see, even from that beautiful folders, the discipline hasn't changed much in the last 150 years. You still have a human expert look at the gas slides mostly and render their diagnosis. At the end of the day, these slides end up in vast archives. So Memorial, for example, has 25 million of these slides, produces 1 million a year. Large labs in the US produce 25 million a year. and then they are stored here, and it's really a pristine example of dark data where it's mostly not used. And it would be great, of course, for science and clinical practice to learn from all that data. When I started in that field a long time ago, when we wrote the first computational pathology paper, actually the images were really bad, so you couldn't even compare to human perception. But these days, scanners are good enough, and you can digitize at high throughput that the images have the quality you need. So here's a skin example, you can zoom in, and you can see the cells and the nuclei and the staining, etc. And you're interested in detecting cancer, quantifying cancer, and predicting all kinds of outcome, if possible, response to treatment, survival, and so forth from these slides. Why is that still important, or more important than ever? If you see on the left side, disciplines like radiology and lab work and ultrasound and so forth, they are to some degree screening technologies. As soon as you see something, you have to take a sample, put it on a microscope slide, and then the pathologist looks at it. And the diagnosis of the pathologist is the basis of everything else that follows afterwards: treatment decision, testing, sequencing, all pharmaceutical studies, etc. Very practically, that has huge impact on how the FDA, for example, clears systems. So there are dozens of AI systems in radiology with the argument it's just screening. If it doesn't work that well, the patient will come back and they're just going to do it over again. While in pathology, it influences the diagnosis and hence the treatment of the patient. And to this day, what is it, May 2021, there's not a single AI in the US that was cleared by the FDA for clinical use. Not one. So speaking of hype, there is, if you really want to be compliant these days, you can't even use AI for clinical sign-out. And of course, we want to change that and hope it's going to change very quickly to the benefit of everybody involved. But that's the lay of the land today. No AI, nothing. But pathologists are, of course, under enormous stress. So the number of cancer cases goes up, the complexity of cases goes up, the number of pathologists in the US goes down. And although it's still better here than in vast parts of Europe and the rest of the world. And of course, the more you work, if you work more than 40 hours, the error rate goes up. That's an Australian study. That's true for every discipline. So the way we think we can help is computational pathology. So computational pathology tries to go beyond image processing, computer vision, and it's not just biostatistics at the end, but you really have that holistic approach to pathology where you use computation to extract information from these slides. From a research perspective, my lab works in 3 areas. The first one is, you can say, the diagnostic area. So these are mostly techniques pathologists use today, or things pathologists can do today, like detection, counting, and so forth, but where you want to develop tools that help them to be more efficient, more reproducible, more quantitative. On the other hand, on the prognostic side, we are interested in systems that help pathologists to see things they can't see yet. So for example, try to predict mutations, molecular alterations from H&E slides. Try to predict response to treatment, for example, IO in lung. Try to predict outcome in terms of biochemical recurrence or survival from H&E slides. And all of that is underpinned by a lot of work in computer science and machine learning. We build large compute clusters to be actually able to process tens of thousands of slides. We build healthcare informatics systems that help us to combine data sources. We build viewers, for example, that help us to better view, annotate, and show results in these very large images. So where are we today? That's a little bit outdated, but it's not much better these days. So most of the work is done on very small data sets. So here you see on the x-axis size of data sets over the years. When we started computational pathology 15 years ago nearly, we had one tissue microarray slide. And these days, data sets are usually 500 to 1,000 slides. The problem, of course, is that these academic data sets are usually very well curated. So all slides that are poorly processed are removed, all slides that are not perfect or difficult are removed, and so forth. And practically, that's like training a self-driving car on an empty parking lot where it will work perfectly fine with perfect accuracy, but as soon as you hit reality, it will fail. And that's so much more true in pathology, where what you see on slides can be very diverse and surprising and messy and so forth. So the question is, how can we build systems that are clinically great, that are useful in practice and not just academic toys? I truly think it takes these four elements. And over the last years, many years, I was working towards these four at MSK, at Mount Sinai, and PAGE was also formed in the image of these four goals. So the first one is novel machine learning. There are no off-the-shelf tools that work in pathology. The domain is significantly different to images of cats and dogs and self-driving cars. You have to develop your own systems. We'll talk to that a little bit later. You need enough data to resemble reality, so you need real-world data. You need domain expertise, and that's of course not only pathology and oncology, but it's especially also computer science, where it's tremendously difficult to get experts in machine learning to come to us into hospitals and not just go to one of the big companies where they stratify teenagers or do ad placements. And the last one is computation, which is very often overlooked. Computation is the new microscope. It's the ability to actually analyze at scale. If you do not invest heavily in software and hardware to do so, you're just lacking that new microscope. Was there a question? No, good.
No, I don't think so.
Great. So with digitization at scale, we were able to build models at MSK with 44,000 slides. And these days, top of the line AI systems, for example, at PAGE, are trained, or at PAGE only, to the best of our knowledge, are trained with 100,000 slides. So that's a phase change in that space. And the same way, you could not imagine training a pathologist with just looking at 100 slides. The same way a machine has to see how reality looks like to be able to be reproducible and effective. We built large compute clusters, and yeah, as you see at the end of the day, we are all nerds and very excited about these beautiful GPUs you see on the bottom right, as you hopefully can follow our enthusiasm there. Good. For time's sake, I'll skip all of that. So one of the biggest problems in practice is manual image annotation. So the classical approach you see on the left is a pathologist has to sit down and annotate these images. For example, in that case, draw around Gleason grade 3 lesions, label it, and so forth. The problem is it's hugely limiting. It's very subjective. You probably don't have subspecialized pathologists doing that hours and hours, and you can't do it at scale. To overcome that, we came up with a new approach shown on the right, where we train systems directly from images against the pathology reports. So we can take fields from the pathology report, for example, the presence or absence of cancer, the grade, if there's ASAP or whatever is in your report, and directly train against that label without manual annotation. The problem in practice is, of course, that the information could be hidden on the slides. Here you see 2 prostate biopsies, and if you zoom in, the cancer lesion is really tiny. So again, there are no off-the-shelf machine learning systems to solve the problem. We address that by building a multiple instance learning system where you can imagine it works as follows. You have 2 stacks of slides. One stack, you know, all of these slides contain cancer, but you do not know where it is. You do not know where it looks like. And the second stack, you know, there is no cancer. These are all normal or benign. So what the system does, it compares these 2 stacks of slides over and over again until it realizes or learns what the difference is. And the difference are not the pen markings or folds or the pre-neoplastic processes or the mimickers of cancer. The difference is the cancer morphology. More specifically, so we tile, go back. So we tile the image into tens of thousands of small patches. These patches are then passed through a convolutional neural network. You end up with a ranking of these, and then you compare them to the slide label. The hypothesis there is that if it's cancerous, then at least one of these small patches is positive, cancerous. If it's a large lesion, could be more. And then if it's a benign or normal slide, then you have none of these. Based on that, you can calculate a loss function, back propagate it through the system, update your parameters, and that's how the system learns. When you predict a slide or do inference on a new slide you haven't seen before, you run the system over the whole slide, you end up with hotspots, and then we use a recurrent neural network or different kinds of aggregators to come up with a slide level label. And the point of that slide is that these systems, for example, do not work if you just do it on a few hundred slides. But if you train on 6, 7, 8,000 slides, the AI starts to learn how cancer looks like, where to find it, how to differentiate it. And if you do that on 100,000 slides, then you get a pretty good model of cancer morphology for a specific organ type. We tested that on prostate skin and breast cancer lymph nodes. You get nice AUCs. You can then also do some mathematical gymnastics and use the system that was trained only on these binary labels to actually annotate the slides, show where the cancer is, and give the confirmation to the pathologist. At that point, you should be still very skeptical because the only thing I showed you were some AUCs, and maybe the MSK data set is completely biased and everybody has nice AUCs. So who knows if the thing actually works. So what we did here was that we tested it on 12,700 patients from all over the world, from 800 different institutions out of 45 countries. So there, the pre-analytics were done in China and Europe and South America and all over the US. And the system nicely generalized to these slides. The plot on the left is one from the Nature Medicine paper, but the state-of-the-art systems see no drop here. So that means if you have slides from France, which are still stained sometimes with saffron in addition to H&E, or if you have thicker and thinner slides, like a human, where you are able to generalize about over all these things, the AI has to do so as well. And clinical grade means here that every slide that was good enough for a human must be good enough for the machine. So there was no data curation done whatsoever. Then you can do model introspection. You can see what the model is doing inside. You can show how it works. So that's easy case. There's a lot of cancer. And then you have a nice system. But that does not answer the question, how would it actually impact a pathologist in clinical practice? So we did until now a number of studies, and this was one of the earliest ones with pathologists throughout the US, which was published last year in Modern Pathology. And what you see here is on the right are the results stratified by lesion size. And you see the sensitivity of the pathologists in black, and then in yellow orange you see the sensitivity of the pathologist plus AI after a washout period of 5 weeks. So as you can see, if you have community pathologists, they do miss a lot of small lesions, so 50% actually. But when they have the system that helps them to actually find them, they recolor them. And in all these cases, there was no loss of specificity for this system. So if you are, for example, a urologist and you rely in your treatment decision on the number of involved cores, that's of course a very meaningful quantity. And here the system can help not only pathologists to maybe be more efficient or more confident, it especially helps them, the patient, to get the right treatment. And the community pathologist is, of course, completely overwhelmed by work, and not a subspecialized pathologist, it's you. You can then use these systems to do a pathological complete response assessment, for example, on whole slides. So there, again, it works out of the box without problems with atrophy, for example. You can use the same approaches to predict the grades. So the system is able to predict the different lesion grades and pre-fill, for example, your report. And here's another study that's quite interesting, where we had several pathologists in Brazil, actually, who were looking at the slide. So these were actually subspecialized pathologists. And as you can see again in the comparison, in all these cases, the AI did help them to improve. And yeah, that's more detail on that.
Sorry, I have to jump in. Page by itself was better than the combination?
In this case?
Yes.
So yeah, so here you don't see the specificity, but yes, here you see actually both bars. So you see some loss in specificity. That was the study from Brazil. In blue, you see the AI by itself, and in black, you see the pathologists. Keep in mind that's not for diagnosis, right? The system does cancer detection, and that's something actually it does very, very, very well. It helps you find the needle in the haystack. Of course, as a pathologist following CAP criteria, you have to do so much more than just find the cancer, right? And you can look at all kinds of other things. But just for finding the lesions, we are approaching a stage in pathology where for some cancer types, these systems do very, very well. And
I just wanted to follow up on that, and I would just highlight that this Alex Bears from Hopkins, this distinction here, I think is nice, because a screening system, you would actually want it to be leaning towards higher sensitivity at the cost of specificity. And as you're describing it, then the pathologist will go afterwards and will have his or her perspective tilted the other way, where they'll be more specific and potentially less sensitive. So that kind of makes sense in the context of a proposed screening approach.
Yes. Thank you, Alex. Yeah, I do agree, but just to some level, I mean, it's if your specificity is so poor that you get false positives all the time, like it was the case with early radiology applications, then the thing becomes useless. So we just finishing the write-up of a new study which will be the largest with the most pathologists, and there we actually don't see even a drop in specificity. So that will come out soon. So in this case, that might be still an artifact, and it's also the system that was 2 years old here. What was more interesting here, it actually found 4 cases where all the pathologists agreed there is no cancer, and the eye saw some. And only after staining it was confirmed that there was actually a cancerous lesion. So these are interesting from the biological side, of course. What kind of morphology led to that decision? Okay, finally, of course, the impact on the patient is the most important one. So the beauty of that is you can actually run that everywhere on the world. So it's really a tool to democratize knowledge as well. Not everyone can afford to go to Mount Sinai or MSK for the treatment. And if you have some camera mounted in sub-Saharan Africa, you can still analyze that using these systems in areas where you don't have pathologists very often. You can also use it to, for example, run 100% quality assurance. Did you actually find everything? That should prevent cases like we saw a few years ago when single pathologists led to a lot of misdiagnosis. So that helps the whole system and gives, again, confidence to the pathologists that they haven't missed anything. We're short on time, so I didn't talk much about predicting molecular alterations and response to treatment, but these computational diagnostics, these computational tests will play certainly a significant role in pathology going forward. And again, all of that will be done by pathologists. I want to thank all the teams involved in all the years of work and all the collaborating experts on Mount Sinai, MSK, and far beyond that. And yeah, thank you very much for your patience and interest.
Thank you for coming to our workshop, and I'm sorry you missed some of the earlier discussion. We had a lot of interesting things, but now you get hit with questions. So the floor is open. Sharmista posted in chat, and I'll read it for her. She likes good questions. She asks, is it possible AI will be an automated process for pathologic assessment, but maybe not superior in terms of what an excellent pathologist can do to come up with a precise diagnosis? Are there efforts towards marrying AI based on multiplex images? We've been talking a lot about multiplex images today, Thomas, with AI algorithms on radiological images, again, for both of those, trying to see things that are hard for humans to see, especially with the more complex data. What are your thoughts on that?
Yeah, so there were several questions packed into one. Let me start with the diagnostic side. So I think a good way to see these systems is they're like a computational IHC. Right? IHC does not do your diagnosis, but you can use it to help you. Right? The same way you would use all kinds of information from these computational tools to help you to find the cancer, quantify it, and so forth. Right? Count mitosis. So all these annoying things where it's very useful to have a reproducible system to do so. The final diagnosis will still be rendered by pathologists for a long period of time. And if you think of the future of pathology, and that's why it's so exciting, in five years, when you probably all will be digital, you will have a cockpit where you have the molecular pathology information, you will have the computational pathology information, and then in addition you will still have the slide. But it's up to you based on all that to come up with the final diagnosis. So the role of the pathologist will be much more important in the years to come, especially also for treatment decisions. These computational tests that predict, for example, response to treatment will be absolutely key for all kinds of precision medicine approaches, where you want to know, is there I don't know, TSC1 mutation, so you can give them an mTOR inhibitor and so forth. So pathology will be very, very exciting there. There will be, maybe there are some edge cases that are truly only detection, where the AI can do all the early screening, but in most cases it will be done. Towards multiplexing, or these days people call it spatial everything, right? You have spatial genomics and transcriptomics and so forth. These are fabulous tools. They are very deep, of course. Sometimes you can have 100 different markers, but very often only on tiny pieces of tissue, 2 millimeters, or just 10 patients or 20 patients. So to that end, it's very orthogonal what we try to do on H&E. It was a very deliberate decision I took some time back to focus on H&E. H&E gives you the ability to look at morphology at breadth. So it's wide. You can learn from 100,000 slides in prostate alone. You cannot do that these days in multiplexing. So these multiplexing approaches are tremendously interesting from the science side, but it's very hard to build robust, reproducible systems if you only have a few dozens of patients. Where it gets very interesting is when you combine both approaches. So for example, you could use dedicated multiplexing platforms as ground truth. So you see, for example, different kinds of T cells or specific morphologies, and then you use virtual or actual staining to see it on H&E, then train systems that can detect the same thing on H&E, and then use it at breadth again as a screening, for example. And that's going to be very, very exciting. So it's just another tool in the tool chest of pathologists. Any additional questions?
Alex,
I'm sorry, I was speaking on mute.
There you go.
I was going to call on Alex before you, Richard. I think he had his hand up.
Oh, sure. No, I agree.
Sure. Alex Barris. Yeah, hi. One more question. So I think what you just brought up there is kind of the difference between, in the H&E space, most of the time we're not talking about segmenting nuclei and segmenting cells most of the time, although there are certain analytics that do that. Versus in the multiplex space, we're almost always talking about segmenting cells, largely because people want to attribute the signal measurement of the molecules that are being measured. What are your thoughts on approaches that look at this multiplex data, but don't necessarily segment out cells and take a more almost H&E-like approach to that data? I don't know if that's something that makes sense, but just asking your thoughts on that.
Oh yeah, absolutely. It absolutely makes sense. So very generally speaking, I would not differentiate between the methods so much. We use both approaches in both modalities. For example, on H&E, what I showed you briefly today, for example, the Nature Medicine paper, that's purely morphology based, as you described. Nevertheless, for example, for IO response work we do, we have mixed systems where we mix morphology with actually detection of cell nuclei, and then get all kinds of spatial features, all on H&E, to, for example, count the tails at the interface on the stroma, etc., etc. So you do not have to do either or, it's both. But you're right, in multiplexing, the community seems to be a little bit stuck on the cells themselves. Very often, not even detection, but segmentation of these, because it's more or less the first thing you think of. There are fabulous tools these days in spatial machine learning and spatial point processes, where you can go far beyond these simple approaches. But I do think that, especially when you think of the approaches where you have dozens and dozens of channels, that that more morphological or approaches could make a lot of sense. In addition, the morphological systems I was describing, they're trained end to end, which means it gives the potential to the system to come up with new features and new relations. If you have this intermediate step where you detect only the cells you already know of, then of course you can't find anything new. That said, because these data sets are usually so small in terms of patients, you very often do not have another choice than to actually do a lot of modeling, a lot of human assumptions to get some signal out of it. It's difficult, but certainly exciting.
Thank you, Richard.
My turn, yes. Hi, Thomas, glad you made it. So I have two questions. One is, we keep reading in the AI world about how AI is really, really stupid compared to a 2-year-old who can sort of generalize almost instantly once they see a cat. They don't call cows cats. And there are things called, like neuromorphic computing and completely sort of orthogonal, structures for this. So that question number one is, what do you think about alternatives to what is now sort of classical AI tools?
So, I mean, stupidity is as poorly defined as intelligence, of course, and usually.
Sorry, I didn't mean to be cast aspersions.
Yeah, no. I mean, you're of course spot on. There are questions about generalizability, but with humans, of course, we have not the slightest clue how the brain works. We do not know how much modeling is actually done before, how much knowledge is there. There's obviously a lot of work that all kinds of 3D perception is already present, right? It's really not the case that you have, let's say, a randomly initialized neural network and the human sees 2 cats, right? So there is a lot of going on before that. Also to that end, right, our artificial neural networks have also nothing to do with the brain, right? That's to a large degree a complete misnomer, and I do not care too much, right? It's I think bio-inspired approaches can lead you astray. Right? I do not want to fly in an airplane that works like a bird, and I do not want to have an AI that works like us, where you have all our problems we humans have. We want something that's orthogonal and that can do a specific task very well without getting tired or being too biased. Very classically, there are, of course, symbolic approaches. There's the whole symbolic community, but that in the past did not lead to too much success, and it's really unclear to this day if you have to go to symbolic computation at all. A lot of that comes also from the linguistic space, and there's a vast and rich tradition, of course, but until now, we didn't hit any point where let's say, we couldn't learn automatically what could be done. Also, look at transformers in NLP. Regarding additional hardware like neuromorphic computing, there are certainly a huge space of potential improvements. It's the hardware we have today still comes out of the gaming past. They are good for linear algebra, and hence our systems are built on linear algebra. They are getting more specific these days, so there's a lot of GPUs which are designed already for deep learning instead of gaming. But there are, of course, very exciting approaches of companies who go beyond that.
So I have a completely separate question, because I've become interested in saffron. I didn't even realize it was a major component in European staining. By the way, for everyone else, it's H&E and S, HES, and the saffron can stain the collagen yellow. And my question Thomas, is do you find saffron, if you just look at, let's say, just the French data, does HES perform better than just H&E? Is there anything in there that's adding to your analysis?
No, not in our case, because we only tested on these slides, right? It was trained on the classic H&E slides, and so the saffron didn't bring the algorithm to fall. But since it wasn't trained, it also couldn't take advantage of additional structures that were stained with it. But good point, yeah. They certainly also smell better. I don't know.
Taste better.
Yeah.
Yeah, so it's a good question. You open up a good question, a good line of reasoning. So as we do more of these multiplex analysis, we may be able to stretch what you can do from an H&E, which is what you said, Thomas. And certainly, you know, we know of efforts to do this and correlating what you see on an H&E with the, for example, in breast cancer, intrinsic subtype is something I know a lot of people working on. And for now, we have, of course, we like to take shortcuts, but we really, in order to get an accurate intrinsic subtype, we need the gene expression profile. The question becomes, and it's sort of related to Sharmista's question, as we get into more complex data, that's hard for us to look at. And part of the reason I think that we in pathology use an H&E slide is that that's about the level our brain is comfortable with looking at. We're looking at different shades of pink for protein, and we're looking at nucleic acid, mostly nuclei, for the hematoxylin. And we use a lot of immunohistochemistry these days, but we like to look at one color at a time. We're not very good. You know, we've got a few assays in the clinic where we may have 2 or even stretching it to 3 colors, but it strikes me that things that are difficult for us to do on an H&E are also going to be difficult for the machine to do on an H&E, and that having more information is going to be good. I like to give the example, Angelo, of prostate. If we just automatically had a basal marker on every prostate biopsy, it would actually be easier for us to be accurate, specific, and sensitive when it comes to prostate cancer diagnosis from those very thin corneal biopsies.
You know, we've talked with the fellows during sign-up many times. Man, it would be nice to have an AI. It seems like a straightforward thing to do. I don't know if Alex Barris or if you guys have already tried to do that. It probably wouldn't be that hard. You could just train it on, maybe, I don't know how many thousands of slides. I guess that's a good question. Would we need 10,000 slides stained with P63 or basal cell marker, or 1,000, or what do you guys think? Because I mean, you have hundreds of glands on a whole slide if it's a big slide.
So first of all, to send this question. So of course, the more information, the better. So if I could magically live in a world where we would just have 100 channels on every slide, of course I would take it any second. Absolutely, everybody would. Of course, at that point you need more AI to make sense of it, because you have a lot of nonlinear interactions between these different stains, of course. But if we could do that, absolutely, without a doubt. The situation we are in today is just purely that it's currently we can't, right? We can't even stain all useful IHC stains on all the cases we would want to. Angelo, to your question, so you do not need thousands all the time. What we were very successful in doing is to use approach of transfer learning, for example. The same thing with mutation prediction. So even if you look at MSK impact with the 50,000 cases, if you stratify it down by cancer type, mutation, and variant of interest, which you could actually target, you still only have very often just 100 or a few hundred slides. So what we can do is we can take the clinical systems, for example, for detection, that are trained on 100,000 slides, that do understand your organ type very, very well, the normal morphology, the cancerous morphology, and so forth. And then hit the ground running on your smaller study set where you have only a few hundred slides, but for example, the mutation status, and then use that to train against that target. Right? So, and that works much, much better than if you would only use 100 slides, because you get all the knowledge of the breadth of morphology from the 100,000 slides.
Cool. So as a
What do you think,
practical,
Alex? Can we flip a switch to turn on our basal cell marker instead of ordering a stain that costs a lot?
I mean, you can. I mean, you can. I mean, all of you can try these systems, of course, and so
that to me seems like a super powerful and intermediate thing that might make it through the FDA, which kind of leads into my my next question. So, back in the early days of digital photography, people were critical of us using JPEG compression because it's lossy compression, and they tried to argue that I was now looking at an image that wasn't accurate data, which I always poo-pooed. I said, the JPEG is just fine. But when we get to AI methods for enhancing images or enhancing color contrast, I think we have a similar question that a lot of people are going to ask, which is, to what extent have you made up? And when they say made up, they really mean falsified the data in order to make it look good. And certainly we've all seen examples of AI algorithms having hallucinations. And so I'm curious about how you think that kind of concept is going to get through the FDA, and whether we have to carve out very specific questions for the AI, at least up front before we. And
Yes.
I'll just say, at this point, this question is open to anyone who wants to comment in the group. I think this is open forum in this workshop. I'm not trying to put Tomas on the spot, so anybody else feel free to answer my question.
I'm happy to start here. That's exactly why you want the FDA cleared system. If you take some random AI algorithm that was trained by someone under their desk and you LDT it on 50 cases, you will run exactly in all these problems. It will not generalize. It will not have been shown to be generalized. If you need systems that you have to calibrate for your site, then you're already lost as soon as you get some consultation cases from outside. You do not want all of that. And you do want the FDA cleared system. And the FDA's position in pathology is that you can only do that on FDA cleared scanners and on FDA cleared viewers. And then have FDA cleared AI on that. And there the burden of proof is of course very high. We were very humbled in beginning of 2019 to get breakthrough designation by the FDA. So we got the first breakthrough designation for an AI, not only in all of pathology back then, but all of oncology. And that's because we could show that it will impact patients. But still, even in that luxurious position where you can talk with the FDA on a weekly basis nearly, it's now more than two years, right? The FDA takes the thing very, very seriously, and that's good. It's good for the patients. It's good for you as a pathologist. If you yourself would have to sort out 500 different algorithms and to find out which one actually works or not, then that could never be the case. And it's good for the patients, of course. Right? But it's an enormous effort, of course.
Yeah. Other
That's
thoughts?
the right thing to do.
What do you think, Angelo? What do you think, Alex?
I think I agree with basically everything that was said there. I think what we've seen is that the guidance, at least from pathology governing bodies, along with larger, more overarching like the FDA, is at least in the first few iterations here, you'll want to present the pathologist with at least an attempt to explain what the algorithm is, why or what the algorithm is thinking. So overlays of things on top of images that they're conventionally able to interpret. So as you saw, Tomas showed, heat maps over the overlays on top of the conventional H&E imaging. Similarly, in quantitative image analytics that are being, governance around how to provide guidance to pathologists who are counting IHC or mitoses for that matter, to identify what is the denominator of cells, what is the numerator of cells, so that the pathologist can understand the number or the probabilities that are being spat out by the machine. I think, at least in its first iteration, to generate trust around what's happening is very important. I imagine that there's similar types of thoughts in radiology as well, because you just don't want this black box feeling. You want to understand what is driving certain metrics coming out from a machine learning technique.
Yeah, I couldn't agree more. And so you don't want to just have a binary label that says, oh, there's cancer in that case. It should point it out. It should show it to you. If you do mutation prediction, you should show what kind of morphology led to that and so forth.
The other comment I would make, Alex, or everyone, it sounded like, Tomas, you have two major applications that I could see that are right away almost. One is increasing our efficiency. So, when I visited Finland a couple of years ago, the pathologist's friend, his office was very stacked with slides, all clinical slides. And I'm like, do you guys have enough pathologists in Finland? He's like, no, we don't have enough pathologists. So at that point, like if you could make us, or if the world could make us 20% more efficient at doing what we already do, I think that would be a huge win, and probably at the same time make us better, as you're saying. Maybe make the experts a little better, but maybe make the community people a lot better and more efficient. That sounds good. But the other thing, it sounds to me, you're also saying you'll probably make us way more sophisticated. So we could predict a BRCA2 mutation on top of whatever else we're doing, and that reminds me of HemePath, right? HemePath is a lot ahead of us in the solid tumor because they have all these markers, they have flow, they have molecular, but that's because they have accessible cells, in my opinion. But you need to have more training in HemePath now, not less, in order to sign out a case, right? And so I think what you're getting at is that at least a subset of pathologists will be these super sophisticated, and you're going to need maybe new training programs to make them as good as we can be. Is that sort of where you were going with that?
Yeah, that might be true to some degree. So I do think that the very simple repetitive tasks will go away, right? So like cancer detection, like all kinds of counting tasks and so forth. You don't want to spend your afternoon counting Ki-67 and all these things. So and I do not think that anybody will miss them. But you're right, if you have all these computational tests that tell you about fusions and alterations and so forth, pathologists will have to know what to do with that, right? You also don't want to yield that area to the oncologists, right? You want the pathologists to be in the center of that process. And it should be the pathologist who then decides that, okay, the eye predicts a specific mutation with I don't know, 70%, right? And it's up to you to decide if you would, let's say NTRK, you would go with a fusion with a stain or with a sequencing approach or some other assay. And that's, being a pathologist will be much more exciting. I'm sure of that.
Yeah, and maybe multidisciplinary tumor boards, there'll be a Zoom call every Friday or something. Mm-hmm. But the pathologists will have to know a lot, I think, is what you're getting.
Tomas, I have a question. Since we're hearing a lot about vaccine hesitancy, have you heard about AI hesitancy from the lay public? Like, I don't want my tumor to be diagnosed by AI. I want a human being looking at it.
So again, we don't have a cleared system today at all, right? So if your hospital did not LDT something in some Wild West manner, that question does not arise yet.
I meant like, did you guys do any market surveys in this? Like, what's the future like? Will people, it's like or GMOs. There's still a lot of hesitance about GMOs, even though the safety has been established. And people say, listen, I don't care. I still want Dr. DiMarzo or Dr. Borowski's eyes looking at my slide. I don't care what fancy AI you have.
Yes.
But that's gonna happen no matter what. That's true for innovation in any field. So I think what you're looking at is when the experts adopt it and they say, I want my eyes in combination with AI, that makes me better, the field will change. So you guys are the opinion leaders, the KOLs, you've got to change. That's what's going to change the field.
You're totally right, Laura. And one of the things that I talk about, but you will never hear pathologists talk about almost to a person, is that pathologists are, we're frequently the gold standard, right? We're frequently I've got a new assay and it can tell whether you have cancer or not. What's your gold standard? It's what the pathologist says. But Dawn's group is fantastic at showing that that's not necessarily true. There's a lot of inter-observer variability, even when it comes to cancer versus benign. I mean, it gets worse when we talk about ADH and DCIS, of course, but it's not perfect even at the extremes. And why is that? Well, it's sampling issues. It's true difficulty in interpretation where some things that are benign look a lot like cancers and vice versa. And so anything we can do, and I think AI is going to be one of those, to improve upon our ability to give a correct, both, sensitive and specific diagnosis is gonna matter. And then the next phase, of course, which is what we're working on, you and I in the consortium, is just because this has been called cancer for 30 years does not mean that it's a malignant neoplasm. It may be a benign neoplasm that looks just like another neoplasm, which is a malignant neoplasm. And we need to be able to sort that out using cues that maybe Path AI and Ping AI are going to be able to sort out.
Yeah, using outcomes. Let outcomes re-educate what we call things, and the leaders are going to, and there will be a bunch of detractors among your colleagues who will constantly be flailing at you. But as Judith Folkman used to say, if you don't have a lot of arrows in your back, you're not doing anything very interesting. So, that's just the way it goes, and you just have to ignore it and keep pushing on.
Sandy, can I show a couple of slides on the dangers of AI?
Sure, why not?
All right, why not? So,
So Richard, you're now shooting the arrows that were.
yeah, exactly. Well, this is, I give a, let's see, you can see my slide?
Yeah, we see your chat bot.
My chat bot. So chat bot, this is a few years old now. Basically, you could put a picture in and ask the chat bot to tell you what it saw. And so I sent up a picture of our unfortunately deceased dog, Tess. Isn't she gorgeous? And she was an SPIE conference co-chair dog for at least a couple of conferences. So I asked them what it saw, and it saw a dog is laying on a couch with a remote. Well, okay, close enough. How about this? Should be easy enough. This is what it saw: a group of horses standing in a field. And finally, one of the famous pigeons, and this is a close-up of a banana on a table. And so it seems fair to ask, is this what you want diagnosing your cancer? And the answer is no, thank you.
But I would be happy to have AI tell me that, as I scan the slide, I didn't see a certain spot that it's concerned about, or even flag that spot to me in advance. The pitfall is I only look at that spot and I miss the cancer that the AI didn't see in another spot. So we have both problems, but I know that the computer is going to be much more tireless in evaluating every level of every slide with the same level of attention.
Yes, and there's that famous study a few years ago where they gave radiologists lung images, and they were asked to find the metastasis. And there was also a gorilla that was stuck into the lung, a very obvious gorilla, and 70% of the radiologists did not see the gorilla.
So
they weren't looking for it.
Yeah, exactly.
So Richard, of course, in your slides, very amusing, but you used, of course, a very cheap rhetorical trick, right? You took a random system and put it past Prototo for all of AI, and
exactly what Tomas told us you can't do.
That's right.
Yes.
No,
So
this is-
that's why, just to finish the argument, that's why you want regulation, right? Because now it would be on you to decide if you want to use that system or not. Of course, in this case, you don't want to.
I don't think
And
so.
this thing would not have gotten FDA regulation for, let's say, animal recognition, obviously. But in reality, there's of course huge pressure on the FDA to loosen their stance, right, and just allow all kinds of stuff. But that would hurt not only pathologists and patients, it would also hurt the computational community, right? Because the people who take it seriously, who invest enormous amounts of time and money and their lives in building something useful, that should not be set on the same stage as someone who's just trying to hustle, right? So I do think that proper regulation will help all of us.
There was a question in the chat from Boostra. You can just ask it, or Sandy, you can ask.
Oh yeah, I see it. Okay, so the question in the chat from Versa Osbeck is, since some of the current tumor grading systems like Gleason grade are made based on eyeball of a human being, do you think we might also need to change some of the grading systems when AI becomes more widely used? And I'll just say that's kind of what I'm referring to when I say that we diagnose things as cancer, and they really are not potentially malignant by themselves, at least not the sample we see. And that's certainly the case with the Gleason 3+3, although maybe there's some controversy about that, which we could get into. But you know, what are people's thoughts about that? Or how are we gonna go beyond Gleason or beyond combined histologic grade for breast cancer?
You know, I think what might happen is, and I think Laura brought this up, if we start training on outcomes, so we'll have a big data set that, you know, experts Gleason scored, and I think we've already shown, not we, the world has shown they could match that already as in terms of Gleason grading, but we know that's not perfect. But if I guess, and Thomas maybe could comment, how big do the data sets need to be to train them on outcomes? And then we show that it actually outperforms Gleason scoring using the AI. I guess we'll be a little bit nervous if we don't understand how it did it. But if it clearly outperforms it, then I think ultimately we're going to have to figure out how to adopt it, right? And especially if you start predicting drug response, you know, who's going to respond to what. So
yes. So you're hitting the nail on the head. What you really want to do is you want to train these systems against outcome. And hopefully at one point there will be a Gleason plus or some more reproducible approach to that. That said, I mean, it's still amazing. Gleason is still the best thing there is, and that's morphology on H&E. Right? You cannot sequence something that beats Gleason. That shows to the power of H&E and morphology. So it is outcome, and the problem, of course, for outcome is getting outcome data, producing outcome data. Especially in prostate, we have these long studies. There are some European long-running studies, as you know, for decades, where you get some outcome data, but that's a huge problem. And the reason most AI systems these days are just trained against manual Gleason grading is because there is no outcome. I have a more positive additional example, and that is in cholangio. Unfortunately, of course, in cholangio, the survival outlook is not that good, and these are also smaller data sets, so even MSK only had a few hundred to do so. Nevertheless, I have a very talented student who did work on survival prediction in cholangio, and he could find potential morphological subgroups that separate outcome in cholangio, and that's, for example, an organ type where there is no grading today. Of course, that's very early work, but that hints at the possibility to find some morphological patterns or a signal we don't know yet. Generally speaking, I still think we are in early days in H&E. There's so much information hidden, and we just lies there for us to discover in the years to come.
So, Sharmista, as usual, we've opened a new can of worms.
Yes, Sandy.
We're going to be looking for ways to fund these new questions that we've all been asking, and we look for your guidance. Do you have any comments for us? I know the NCI believes in this. I know you and Sudhir understand what we're up against.
Of course,
and
we
the
are very
outcomes question.
supportive of this. Now, we are supportive, and you know, other NCI colleagues that we have
Oh, yeah.
that can also comment. But I thought this was a fabulous meeting, which always is the case.
We have
All right, last
those.
words, anyone, before we close the meeting?
Dr. Woodhouse, Patriotas.
Oh, yes, I would just echo Sharmista's comments. A great meeting. Really enjoyed it.
Well, we really appreciate the support we've gotten to put these on and interact in this way. This has been, I think we all agree that this has been the most collaborative consortium we've ever been a part of. And we're certainly looking forward to the next generation of it. I think that speaking for myself and maybe Anirban and Angelo and Don was on, we love the emphasis on pathology, and we love the fact that everything is kind of circling around the pathology, but we also see the task ahead of us. And Laura's absolutely right. There's going to be a lot of resistance in the pathology community to changing the way we talk about things, changing some of the terminology perhaps to better reflect the risk related to outcomes. I haven't solved that yet, but it's a mission. So onward.
Well, and thank you to you, Sandy, for helping organize and run the whole pathology working group for these 5.5 years, I guess.
Thank you, Sandy. Thank you, Angelo,
And Anirban.
everyone. This is always such a good meeting, and I always learn so much.
And Chris Amos, I see him.
No, thank you. Yeah, it was great.
Yeah, thanks, Chris. And it seems like everybody's okay with us posting the recording. So Chris, if you can let me know when that recording's ready to go.
Okay.
We probably have a couple places we could post it for people's convenience.
Okay, great. Thanks.
All right, thanks everybody. Have a
Thanks,
good rest of
everyone.
your day, and we'll talk to you soon. Bye.